Hi, Shanae. Thank you for your post. I like your emphasis on privacy and dignity within family assistance centers. You highlighted how emotionally charged these spaces can become, particularly when survivors encounter personal belongings tied to identity, memory, and attachment. As Weber and Mascari noted, disaster settings often intensify grief responses because losses are sudden and public. Your point that private spaces reduce emotional exposures aligns well with trauma informed principles, which emphasize safety, both physical and psychological. Intentional environmental design is not just logistical, it is also clinically and ethically significant. I agree with your distinction between crisis counseling and long term therapy. Hopeful emphasized that early disaster interventions should focus on promoting safety, calming, self efficiency, connectiveness, and hope rather than pathology. FACs are not treatment centers, they are stabilization hubs. This distinction is critical because premature clinical framing can inadvertently misclassify normal stress reactions as pathological. The CCP model you referred to reinforces this strength based short term approach. In disaster, mental health presence often precedes intervention. As Weber and Mascari explain, active listening and normalization are frequently more effective in the acute phase than diagnostic assessments. Your inclusion of cultural and spiritual consideration is insightful. Atten and Bowen note that faith and spiritual frameworks often serve as primary coping mechanisms during disaster recovery. For a Christian counseling perspective, this integration reflects a holistic understanding of the person. Scripture reminds us that God is near to the brokenhearted in Psalms 34 and 18, which highlights the importance of honoring spiritual expressions during grief. When FACs provide space for prayer, connection to clergy, or culturally congruent rituals, they affirm both dignity and resilience. Shanae, from your perspective, what strategies can family assistance centers employ to balance immediate crisis stabilization with the identification of survivors who may require extended mental health support while avoiding the premature classification of normal trauma responses as clinical disorders?